All right, thank you. That was another great talk, but I'm happy to move on to our final speaker, who's Dr. Scott Lawrence from CMS. Dr. Lawrence is the Deputy Director of the Division of Practitioner Services at the Hospital and Ambulatory Policies Group within the Center for Medicare at the Centers for Medicare and Medicaid Services. He's the Government Technical Lead for the Physician Fee Schedule telehealth evaluation. Seems like a very important evaluation. He had been the Deputy Director of the Division of Payment Methods and Strategies in the Provider Compliance Group within the Center for Program Integrity, and the Acting Deputy Director of the Division of Data and Informatics, leading the Healthcare Fraud Prevention Partnership in the Data Sharing and Partnership Group at the Center for Program Integrity, and while in the Division of Medical Review and Education in PCG CPI, he had been a team lead for the Targeted Probe and Educate computer-assisted review of documentation and other projects. Dr. Lawrence actually continues to see patients in private practice, and he's a consultant and expert for fraud investigations outside of CMS. Dr. Lawrence, we're really happy to have you, and hope you can expand our conversation.
Thank you very much, Albert. I really appreciate it. It's been great listening to the talks. The information has been really interesting. I'm going to start to share my screen as I talk. So I will say that I feel some obligation to tell a joke in the beginning of the discussion. And although I know what you're all thinking, that there's nothing funny about telehealth, which of course is true, I did come across a joke about two antennae that got married. The wedding was quite nice, but the reception was really good. So I get to finish that joke before it's over. So we're going to be talking about telehealth in Medicare. I call this bringing care to the patient, telehealth in Medicare. And I want to give a little bit of background first about telehealth and just the physician fee schedule itself, my area of where Medicare is and the work that we do in Medicare these days. So the physician fee schedule, we handle about $90 billion in payments. That's billion with a B, rooted statutorily in budget neutrality. We provide payment for the services of physicians and other billing professionals. So my particular area does not do hospital payments. We do Part B, traditional Medicare payments. But we do set the physician fee schedule, which is used by many payers as a basis for payment strategies. We deal with units of payments, payment rates, resource costs. We update it annually through notice and comment rulemaking by statute. And we're actually almost finished with that now. We have to publish November 1, which is, all of you probably know, is Monday. We only got about 38,000 comments this year on the physician fee schedule rule. So we're heavily working on responding to every one of those, which we do look at them all. And we've been quite busy. So I appreciate the break that this presentation has afforded me from our activities, but we do have a 4 p.m. Eastern Standard Time deadline for some of our work. So after this is over, I'll be back at it. We deal with almost 8,000 individual healthcare procedure codes, and coding granularity is very, very deep for certain services. The telehealth benefit, traditionally, are services that are ordinarily furnished in person that are instead being furnished via a telecommunication system and are subject to geographic site of service, practitioner, and technological restrictions. This is through the authority of Section 1834M of the Social Security Act. We call it the Act, which defines telehealth services as professional consultations, office visits, and office psychiatry services, and any additional services specified by the Secretary. The Act also requires, this section of the Act also requires CMS to establish a process for adding or deleting services to and from the list of Medicare telehealth services on an annual basis, and they must be performed by a physician or other healthcare practitioner. Again, our historic conditions of coverage relate to technology. It has to be interactive. It does not include a telephone, fax, or email. We do have an asynchronous store and forward type of telehealth that's available through special demonstration program in Alaska and Hawaii. We did have geographic restrictions, and I know we just had an excellent talk about rural health and the troubles for people getting care when they live in remote locations. And so we have what are called metropolitan statistical areas and people outside of that, or MSAs that the federal government would like to use acronyms as much as possible. We try to focus on people that are outside of these MSAs to be able to get healthcare to them. Additionally, historically, the authorized originating sites, which is where the beneficiary of the patient is, would be an office of a physician or practitioner, hospital, critical access hospital, rural health clinic, federally qualified health center, hospital-based or CA-based renal dialysis center, including satellites, skilled nurse facilities, and community mental health centers. When all these conditions are met, Medicare telehealth services are paid as though the service was performed in person, and the originating site also receives a flat facility rate. Beyond the Medicare telehealth, CMS also makes separate payment for many other services that utilize telecommunications technology. Statutory restrictions do not apply to these services, even though they may utilize these sort of telecommunications technology. And examples of these include care management services, communication technology-based services like e-visits and virtual check-ins and remote physiologic monitoring. These are things that we've heard about a bunch already today, and I know many of you are probably very familiar with. Then we had something called the COVID-19 Public Health Emergency, or PHE, which changed everything. So as you are probably aware, and you've seen some data, and data is a great deal of fun to work with for some people like me. So we have had some interesting data. I know Dr. Shah would like to see some of your slides again. But before the week of the PHE, there were about 14,000 patients that received the Medicare telehealth service in that week. During the PHE, for example, the last week of April, so we're talking about 6 weeks later, we saw 1.7 million patients via Medicare telehealth, which is a change of around 12,000%. And from the period between mid-March through mid-September, we had over 12.8 million services, which is about 38%. I know that Dr. Shah was saying 43%, and this is an accurate number depending on where you're slicing, and that's how data is. So, you know, we could easily say that approximately 45% of people were receiving services in telehealth at some point during the public health emergency, whereas it used to be less than 1% of all services. So it went from being a very small service that was set up to try and access or get access to care to people in rural areas and other special circumstances, to being a really mainstream delivery system for healthcare. And I'll keep moving forward here. So in 2021, we made a couple of changes to our final rule. Now, we have to do things through what's called notice and comment rulemaking, so that the public has the opportunity to see what we're thinking and comment and maybe help explain something that we are missing or agree with what we're saying. So we did have a couple of interim final rules, which we put in. And as I say, this is a very big project. We had over 38,000 comments this year. Last year in the 2021 rule, we had over 42,000 comments. But we still did a couple of other interim rules in the middle, just because we needed to act fast to try and make sure patients could get needed care in a safe way, or in a way that was as safe as possible, considering how crazy the pandemic was. So these are some highlights I'm going to go through from our 2021 final rule, and I'm going to talk about what we proposed for this year's 2022 final rule. And I know I'm saying this year, but we're always talking about the year in advance. So for 2021, we did add 9 services to the Medicare telehealth list on a Category 1 basis, which means these are services that are similar to services that are already on the telehealth list. We did create a temporary third category, Category 3, of criteria adding services to the list. And these are services that were added during the PHE that will remain on the list through the calendar year in which the PHE ends. We added 58 services Now, as you will all see and all already know, when we wrote that, which was in 2020, we did not anticipate that the pandemic and the public health emergency would carry on through all of 2021. So you'll see we've made some modifications to some of these things, and this is why I'm introducing this for you now. We also clarified that licensed clinical social workers, clinical psychologists, physical therapists, occupational therapists, and speech language pathologists can furnish the brief online assessment and management services, as well as remote evaluation services and virtual check-ins via the two-way HCPCS codes G2010 and G2012. You can see these things if you go to cms.gov, go to newsroom, fact sheets, you can find our things. You can just even do a search for physician fee schedule, and you'll see all these things. You can pick the year that you want. So just to give an idea of some of the things that were added, these are the services that were added permanently in the 2021 final rule. We have group psychotherapy, domiciliary and home care, other types of home visits for established patients, cognitive assessments, care planning, et cetera. You can read these, psychological, neurological testing. So these were added permanently onto the Medicare telehealth list. These are the types of services that we added temporarily onto the Medicare telehealth list in the final rule. And you can see there's additional domiciliary and home visits, emergency department visits, nursing home, psychological therapy services, hospital services, discharge stay management services, inpatient neonatal and pediatric critical care, et cetera. You can see it's a broad scope of services that we determined were best added to the telehealth list temporarily, and we did consider other codes as well that we did not end up putting on the list, but it is a pretty broad scope. We have a lot of people at CMS, different types of medical officers and other professionals, legal teams that considered these, and then again through notice and comment rulemaking, so the public had opportunity to see and comment on these decisions. We also added and had mechanisms to add more codes temporarily outside of the final rule. And so you can see here, we had radiation treatment management services. We had initial observation and observation discharge day management services, nursing facility visits, more domiciliary and home visits, inpatient neonatal pediatric care, medical nutrition, audiology, speech language pathology. So we added some other services as well. Overall, it was approximately 168, I think, or more than 165 services that were added total temporarily to try and help people get care through the pandemic in a safe way. We also finalized some other policies. We finalized a frequency limitation for subsequent nursing facility telehealth visits for one visit every 14 days, ensuring adequate face-to-face care. We reiterated that telehealth rules do not apply when a beneficiary and a practitioner are in the same location, even if the audiovisual technology exists. So they can't be in the same place and do telehealth. We also established payment on an interim final basis for a longer brief virtual check-in via the new HCPCS codes, their G codes, describing an 11 to 20-minute session of medical discussion determining the necessity for an in-person visit, and we'll talk more about that later on. For virtual supervision during the PHE, to limit infection to exposure, we did revise the definition of direct supervision to include virtual ability of the supervising physician or practitioner using interactive audio, video, real-time communications technology. And we were considering this policy through the end of the PHE or December 31, 2021, whichever is later. Well, we already know how that's looking now, but we didn't in 2020, November or December of 2020 when we finalized this. For teaching physicians, we allowed for virtual presence for residency training sites that are outside of the MSA. We established a policy to allow teaching physicians to use interactive real-time audio-video communications technology to interact with the resident through virtual means in order to meet the requirement that they be present for the key portion of the service, including when the teaching physician involves the resident in furnishing Medicare telehealth services. Additionally, with respect to teaching physicians, We made an exception for primary care for residency training sites that are outside of an MSA. We established a policy to allow teaching positions involving residents at primary care centers to provide the necessary direction, management, and review for the resident services using interactive real-time audio-video communications technology. For these sites, residents of primary care centers may furnish an expanded set of services to beneficiaries, including communication technology-based services and interprofessional consults. I can say that for a reason that is unfortunate, this is a very long thing to describe. Communication, audio, real-time interactive audio-visual communication technology. It'd be nice to have a shorter way to say that, but that is the correct description. Further, with respect to teaching physicians, neither of the flexibilities apply in the case of surgical or high-risk interventional, endoscopic, anesthesia services or other complex procedures, I hope for obvious reasons. Further, the teaching physician must render sufficient personal and identifiable physician services to the patient to exercise full personal control over the management of the portion of the case for which the payment is sought in accordance with Section 1842 of the Act, and the medical record must clearly reflect how the teaching physician was present to the resident during the key portion of the service. We also did work on remote policies related to these 6 services would be available to remote physiologic monitoring. We finalized that the patient consent to receive the RPM services can be obtained at the time that the RPM services are furnished. We finalized that auxiliary personnel can perform services described by CPT codes 99453 and 99454, incident to the billing professional services under a physician's supervision. We also clarified that auxiliary personnel can include contracted employees. In addition, we clarified that only physicians and non-physician practitioners who are eligible to furnish E&M services may bill these RPM services. And we clarified that the medical device supplied to the patient as part of the RPM services must be a medical device as defined by Section 201H of the FDA Act. And this device must be reliable, valid, and the data must be electronically, that is automatically, collected and transmitted rather than self-reported. Further, we finalized that auxiliary personnel may provide certain RPM services incident to the billing practitioner services under physician supervision. And we clarified that auxiliary personnel can include contracted employees. We clarified that only physicians and non-physician practitioners who are eligible to furnish E&M services may bill these RPM services, and we clarified that RPM services may be medically necessary for patients with acute or chronic conditions. Finally, with respect to remote physiologic monitoring, after the PHE for COVID-19 ends, we finalized that we will again require that there be an established patient-physician relationship for RPM services to be furnished. And after the COVID-19 PHE ends, we clarified that at least 16 days of data for each 30 days must be collected and transmitted to meet the requirements of CPT codes 99453 and 99454. At the end of 2020, the Congress passed the Consolidated Appropriations Act of 2021, or CAA. A few of the sections had direct issue with telehealth. Section 123 of the CAA removed the geographic and site of service restrictions for telehealth when used for the purposes of diagnosis, evaluation, or treatment of a mental health disorder. Section 123 also requires that there be an in-person non-telehealth service within 6 months prior to the furnishing of the telehealth service and at intervals thereafter as specified by the Secretary. And we'll talk more about this later. Section 125 of the CAA also added rural emergency hospitals to the list of eligible telehealth originating sites beginning 2023. So this came, as you can see, December 27, which meant that we needed to change things again before January 1 of last year in order to everything to be in place and ready to go so that all the providers and payers could take action on it. Now we come to the current proposed rule. So again, we call it a proposed rule because we haven't finalized it yet, but as of November 1, it will be published as a final rule. But this is what we proposed, and the things that we're chewing on and comments that are coming in and working with that. So we dealt with the implementation of the CAA provisions as described earlier. Also, we proposed to amend the current regulatory requirement for interactive telecommunication systems, which, as we've said before, is defined as At a minimum, audio video equipment permitting two-way real-time interactive communication between the patient and the distant site physician or practitioner, to include audio-only communication technology when used for telehealth services for the diagnosis, evaluation, or treatment of mental health disorders furnished to the established patients in their homes. So this is a big change, and one we're working really hard to make sure we get right. A lot of people, as we've heard in lectures so far today, have been using audio only, and with some good effect, but there still are some concerns, and we want to be sure that that we do it the right way when we do it. Again, you can look at the cms.gov newsroom fact sheets, and you can see a general overview of the 2022 fee schedule. Or you can just go to cms.gov and you can do physician fee schedule, and you'll get all kinds of information that way. Other highlights for the 2022 proposed rule. We propose to limit the use of audio-only interactive telecommunication system to mental health services furnished by practitioners who have the capability to furnish two-way audio-video communications, but where the beneficiary is not capable of using or does not consent to the use of two-way audiovisual technology. And this is important. One of the things that I'm sure you've all seen with all the data that you've been reviewing and considering is that we see what we see, but we don't always see what we don't see. In other words, there's a whole population of disabled people or people who just are unable to use this technology at all. And we're trying to see if we have a way to capture them as well. So it's important to us that we capture as many people as we can so that people get access to the care that they need in whatever way is the best and safest way for them to do it, to get the quality care. CMS is also, we also solicited comment on whether additional documentation is required in the medical record for the appropriateness of audio only as opposed to audio visual, which we still see as a standard for these two-way communications, whether or not we should preclude audio-only technology for some high-level services, and also if there are any additional guardrails that we should be considering to put in place to minimize program integrity or patient safety concerns. And program integrity, for those who are not familiar with the language, would be things like fraud or inappropriate payments. And then additionally, for the 2022 proposed rule, for the physician fee schedule, we did solicit comments on the extent to which the flexibility to meet the immediate availability requirement for direct supervision through the use of real-time audio-video technology is being used during the PHE, and whether physicians and practitioners anticipate relying on this flexibility after the end of the PHE. We solicited comments on whether this flexibility should potentially be made permanent, and therefore we'd have to revise our regulation with respect to direct supervision at 42 CFR 410.32. And also, we look to propose to permanently establish separate coding and payment for the longer virtual check-in that we were describing before, the 11 to 20 minute virtual check-in, which is right now used HCPCS code G2252 for calendar year 2022. I'll give a general disclaimer. This presentation was current at the time it was published, and Medicare policy changes frequently, so links to the sources may change. Presentation was prepared as a service to the public and is not intended to grant rights or impose obligations. This presentation may contain a reference or links to statutes, regulations, and other policy materials. The information provided is only intended to be a general summary, not intended to take the place of either the written law or regulation. We do encourage readers to review the specific statutes and regulations and other interpretive materials for a full and accurate statement of their contents. The contents of this document do not have the force or effect of law and are not meant to bind the public in any way unless specifically incorporated into a contract. The document is intended only to provide clarity to the public. And there is a disclaimer for the CPT, which is owned and copyrighted by the American Medical Association. We were using definitions as of the most recent version, which is 2022. All rights, of course, are reserved. That's the end of my slideshow, and I'm happy to take questions from the field if any have come in.
Thank you, Dr. Lawrence. and you ended with plenty of time for questions and answers. So if you have any questions for Dr. Lawrence, please enter them in the chat. I'm actually going to start. I just wanted to ask Dr. Lawrence about basically the policy avenue that you work within that allowed you to make all these changes, basically the rulemaking process. So what you were able to do did not require an act of Congress, correct? That these are things that within current law was possible. And can you talk about the rulemaking process, I guess, in general, from your perspective for the physician fee schedule?
Absolutely. And I'm hoping I didn't put everyone to sleep. And you can't tell when all the screens are blank and that everyone's muted, just how exciting the particular topic was. But we find it to be very interesting. This is a great question, and thank you. So the CAA was through congressional legislation. That's statutory language. And so that already, that's above what we do. Congress sort of makes the solid rules, and then we, deal with regulation and other rule writing, tools that are available through our agency. So much of what we did was done through notice and comment rulemaking, which is a process that where we propose things. They go through an extensive set of clearances within the agency, amongst all different players within the agency and legal teams and medical professionals. Then once we come to a version that everyone agrees upon, it's sent out to the Hill and other political administrative areas, and then goes to the public, and comment is made, and they're given at least 60 days to make comment. We collect those comments and again, review them all, rewrite things if we need to rewrite things, keep things the way they are if we are to keep them the same, then go through again the same really lengthy clearance process through the government. And I'm glad to explain it all, but it really is quite detailed, but important. One of the things that's great about it, it feels like a burden as we sort of go through it, and we have multiple legal teams look at it, multiple medical officers look at it, multiple agencies look at it. Everyone gets a chance to see it. But even with all that, sometimes things slip through that, we didn't, some typo is there or something. Even with all those eyes and really smart people looking at it, things can get through. So it's really good to get, scrutinized by the professionals and by the public in general to get a good feel for what goes on inside. And then once all that is completed, we display and then publish the rule. And then if there's anything, instruction or guidance that we have to put into manuals or anything else, if new codes are made, we make new codes. We set the fee schedule. So this is based on many very detailed areas on what happens in a practice. It has to do with time and time intensity of the practitioners. It has to do with the practice expenses, both direct and indirect, how many how much face paper they use, what kind of computers they use, how much their rent is, what their malpractice premiums are. We consider all these things to set up a payment process that goes through a big machine to what we call budget neutrality, and it measures everything so it all balances out together. It's funny, this was a long answer. It's an actually much longer process. It reminds me of Winston Churchill, who once said that democracy is the worst form of government in the world, except for all the others. So it is necessarily complicated, but I think it's the best system out there. So we're very proud to have this process.
Thank you. And just a follow-up question, how do you know what rules to change or what instigates a rule change? And what do you think still needs to be changed going forward?
Another great question. Thank you very much. So the process of starting the ideas of what gets proposed are varied. They come from stakeholders. So people will write to us or meet with us, and we meet with stakeholders on a regular basis. Even today, in the midst of all we're doing, I have 2 or 3 meetings set up with external stakeholders to discuss different issues of specific services or things like that. And they teach us about what they do and what their experience is in the field and things like that. We get input from legislators who are interested in certain things from their constituents. We get information internally as well from different stakeholders or experts within CMS or HHS at large. And then we also have projects that we already had on our list, but we had to put down because, as you probably gathered, there was already a lot that was going on, and we just don't have the resources to carry every rock across the stream. So ultimately, we do the best we can, and we bring things forward and move them along. As again, if you look at our larger physician fee schedule, the items that I described today are just with respect to telehealth. We have items going on in all areas of the physician fee schedule. So there's lots and lots going on at any given time.
I can only, yes, that is, gives me a headache thinking about that. So I think Dr. Lawrence, well, I think at this point, it's a little bit early, but I think we have all of our speakers here. And so I think we're going to start our extended question and answer period right now, and actually encourage interaction among the speakers as well. There are actually a number of questions in the chat we did not get to. So I may start there.
Yes, I just want to thank you again
yes.
for inviting me and to be working with this esteemed panel. I do appreciate and respect the work that they're doing. And I was hoping, because I did see all the questions in there and saw the amount of work that everybody put in, that I would be able to save some time and give it back for questions and answers for others. So thank you for that, and please go ahead. No hard feelings about my time being cut.
Thank you for your graciousness. There was actually a comment from David Ennis about something I'd never heard of, but maybe others have. So he writes that physicians can lobby state legislatures to limit telemedicine. We've actually spent the whole morning talking about expanding telemedicine. So he cites that there are radiologists in several states that have been successful in getting legislation passed to limit telemedicine radiology services to physicians licensed in the state. How much of a problem is this? What might be done to counter this kind of barrier? I was not aware of this sort of political activity.
Is this directed to anyone in particular?
It is not. It's open to anyone who might know something about this.
So I'm happy to offer.
Yes, Scott, you actually may interact with specialists with different perspectives on telemedicine.
Absolutely. No, we deal with radiologists often and practitioners of all types. I can say that the public, and different public interest groups and stakeholders can absolutely talk to their legislators, both local and federal, to try and see if they can make change in their areas, and we encourage people to do so. We always appreciate comments that come in to us, and we like to see people being active in their systems. I can say as a side note, not a CMS related note, but I do have a good colleague and is one of the finest radiologists in the country. And I know radiology is one of the areas where people across state borders, and I asked him how he handles that, because I know that he does that sometimes. And he said that he's licensed in every state that he practices. So he has many licenses for many states, which pretty much solves that problem. I don't think that the restriction that they're talking about is necessarily aimed at guys like him, because he is an asset, to the health fields for the work that he does. But we do look at states, licensing rules, and we're careful in the telehealth world, because what we want to be aware of is if someone loses a license in a state, we don't want them to be able to go across the border and still see their patients. So we do respect states' rights to be able to discipline and maintain licenses for their practitioner population.
This issue of the practitioner license and where they practice was mentioned, I think, by Sachin and others, and affects, I guess, all this entire area. Could we talk more about, I guess, what states are trying to do is protect the integrity of the professional review process that happens within an individual state, but that slows the process of expanding access to care for people who you might need a doctor in Chicago to care for someone in rural Missouri. Can we talk more about that, the licensure issues and what the battles are over that?
I don't want to take all the answers, so I'm letting someone else have a chance.
I'm really interested, Scott, in your perspective on this as well. Not to punt it to you again too, but I'll just add a little. I'll add a little more perspective on it because for the last 18 months, and you know this as well as anybody, the regulations and the guidelines and sort of the rules have changed frequently. And it's hard to keep up, especially with the licensure requirements. I understand sort of the notion of state medical boards and, protecting their jurisdiction and ability to sort of, enforce their standards. But, medicine in rural Missouri, the clinical standards of care versus in, urban Chicago versus, Boston versus, Appalachia, I would argue that there shouldn't be, or there isn't dramatic, differences in the standards of care. And I know this isn't necessarily, something that you directly have control over, but shouldn't we be advocating for, sort of an interstate, reciprocity to practice medicine in general, telemedicine at the very least, for, to enable this type of care. So to speaking to the equity, speaking to the access, speaking to the capacity issues, and then, from the other side, the growth, because most people, a lot of the populations we've been talking about today, this morning, the problem isn't too much access, it's too little. And I think, finding ways to improve the access to care, are important. So that's sort of my perspective on it, but I'd love to hear your take.
Well, it's interesting. There are a lot of, to me, there are more questions than answers in this area, and we have left it up to the states. We, being CMS, have left it up to states to determine their licensing, rules, and we respect that. Some states do have reciprocity, and some states do not, and they've done that for years. I know my friends in the Medicaid space say once you learn one Medicaid system, one Medicaid system. So it's, when you're dealing on the national scale, it's a little different. And although it is possible that patients are similar across the country, you'll find, large scale payers and people who handle patients across the whole country don't always agree. And so it depends on the type of service, and there's just a lot of variables. There's no one size fits all solution, for this. And then there's the question of, as Elba was talking about, there's the question of when people think that services that should be going to them are going to somebody else for some reason. Why? And is there a way they can protect themselves? And there's so many variables there. But in terms of having appropriate care for the patient, we do tend to lean toward the state's ability to decide for themselves who can practice in their state, and we don't generally get involved in the middle of that at this point. Telehealth has changed things. We did create some flexibilities for that, but we are looking at the glide path for how to deal with that in the future. And again, we're working with states to try and see what makes the most sense, because it isn't just about access; it's about quality, it's about payment systems. Even just considering something simple like what we specialize in is the payment systems. As I just said before, the way we determine how to pay for a given service is extremely granular. We look at what it costs to have service delivered in an inner Manhattan like office space versus rural Wisconsin. The costs to have those services delivered are very, very different. Even if the time is the same, even if the time and intensity is the same, the practice expenses are different. So we pay them differently to be equitable all the way around. Otherwise, every doctor would just sit in rural Wisconsin, and I'm not picking on Wisconsin, but some rural place that is inexpensive to live and do telehealth services to people around and make all kinds of money doing that. And that really isn't the goal. The goal is trying to get the best care to the patients and have doctors where they need to be to get to the patient. The telehealth is just a delivery system to help in circumstances where it's safe to do so. So I don't know if that answers your question, but I hope that it did.
I have a lot more questions. Here's a question from ANN. Why is it okay to use a patient portal to ask a medical question of your doctor in another state, but not to do the same in a virtual video visit?
I didn't hear the last part of that question. Again, I feel like these questions are aimed at me, but maybe because I like answering questions, but I'd love to have other people answer if they'd like to.
Well, it raises the question just about I guess it raises the question about, are we imagining, are we kind of constraining the potential of virtual healthcare because of these rules? If the same thing can be done, 3 states away, 1 state away, why do we have that I was struck by that the 1997 budget reconciliation bill being so important. Why do we still connect things to brick and mortar?
So again, I'm glad to offer. If they are the same, that's one thing, but all services aren't the same. So we have to pick through which services are the same and which ones aren't the same. As we said, we're going to make some changes with respect to telehealth for mental health services. And we've found that we feel that those are substantially the same. Not entirely the same, and not for all mental health services. It is a broad space. But for those that we feel are essentially the same, and we have some flexibility maybe on the part of the practitioner to make those determinations, then it can work. But not all services are the same. And again, the payment structure for these services are fairly specific. So it's not just a question of time. It's also a question of, there are many issues. There's quality, there's program integrity, there's, payment determinations, the amount of time and work that they do, the ability to see things. And for those of us who see patients actively, being able to see the patient in person, patients are not always good historians. They do not always tell you what's going on. So there are some concerns there as well that if it's convenient, if the patient knew everything about healthcare and could give you the quality information you need to make a simple decision, that's one thing. But often they don't. I know in my personal practice, I've had patients that I've asked questions about, and you have to ask the question 5 different ways. If any surgeries, if any operations, if you had your appendix out, if you had, you ask that question like that, they say no, 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 no. And then you take off their shirt and you see a big old scar on their back, and this is a true story. And I said, what's this big scar? And the patient said, oh, had a lung removed. I forgot about that. So in a telehealth setting, you wouldn't be able to capture that at all. And you may make some decisions that wouldn't be in the best interest of the patient, or the patient wants an outcome or doesn't want a certain outcome, and you can't always tell on a telehealth visit. So it just depends on the service. It really, it's not right for everything, and determining which things are good and which things aren't good are very important.
If I could just jump in real quick, Albert, I want to pick up on something Sachin said in his presentation, just to show you I was listening, and I think it was an important comment. Part of the answer to your question, I'm an economist, is that we're still stuck, I think, in a lot of ways, and this is not CMS's fault, with trying to drive a lot of payment through a fee-for-service mechanism. And so, economists have really, Sachin mentioned capitation.
Mhm.
Maybe one of the answers to this is to sort of turn it around. And, CMS and HHS are pushing a lot of these alternative payment mechanisms, reimbursement mechanisms. And maybe the answer is to look at those and, give the providers, the system, some other methods so that they drive the train, and just say, okay, well, this might work in urban Chicago, this might work in, St. Louis, but something else will work in rural America, or something else might work in San Francisco or whatever.
No, thank you. Thank you for saying that, Tim, because yeah, as Scott was talking, the sort of the level of detail and required to make rule changes under the fee for service system is, I think it's accurate to say it's Byzantine. And so to make the shift from in-person care to virtual, I mean, it takes a ton of work on the part of CMS and just and I don't know how this will, it is interesting to, I don't know if we have any data to look at how, whether or not like virtual care was there greater uptake under, Medicare Advantage plans already before the pandemic. I wonder if there's any kind of data to bring to bear about the mode of payment and whether or not that leads to variable uptake of these different ways of delivering care.
And just
So-
that,
Go
sorry,
ahead,
Scott,
Sachin,
go ahead.
please.
Please, Sachin.
Just to add to that a little bit, the thing that strikes me, and I try to show it in my presentation, is around so I think you're right, Scott, that there's not there is different levels of care that you can provide, in person versus video versus telephone versus asynchronous, versus like a patient advice message that you get through the portal. But our patients our patients are also going to go to, at some level, to the path of least resistance, right? Where they encounter the fewest barriers to seeking care, if that's what they need. Some of them are going to be sort of diverted by barriers to care. But one example, just a very close one to us here at U Chicago. I just did an analysis like last month on patient portal messages, patient advice messages, that our patients send us pre-pandemic, February of 2020 compared to September of 2021, the month ending. And the increase, this is just kind of emblematic of this shift that's, that has occurred. The difference in terms of number of messages, patient advice messages that our patients are sending us, among all of our U Chicago providers, ambulatory U Chicago providers, it was up 287%. We have the exact same sort of care teams, the same structure, and our patients are reaching out to us, using this model of care, using this mechanism, this mode of care delivery. So that to me is, that again, I don't think that's necessarily a bad thing. It's a bad thing. It's a hard thing because it's uncompensated care in the current state. It's time that, I answer 10, 12, patient advice requests at the end of the day after I finish everything else. And it's, I'm not getting paid for it. Not that that's the most important thing, but obviously it's, our time is valuable and should be valued. But it's not necessarily bad in a value-based care system, because if me replying to that message and prescribing a medication or adjusting, something, or saying, well, go ahead and stop that, or reduce your dose of this, or, hey, try this. If that prevents them from, showing up in the emergency department later that night or the next day, obviously that's an incredibly effective way to provide care, even if it prevents an office visit for a low acuity thing that could have been handled asynchronously, or even without me, with my MA or my LPN or my RN, at the top of their license, providing that level of care. That's high value care, I would argue. I think the same could be said for synchronous video visits, synchronous telephone visits. I think it should be measured by the value of the care that's provided. And I agree, and I fully admit that that's a work in progress, like assessing the value of that care, assessing the cost of that care, the utilization, the quality of care that we're able to deliver in those, in these, new kind of virtual care delivery models. But that coupled with, the health equity piece, so many of our patients are only able to access care through the telephone for a variety of reasons that I think we've discussed. And to close that off is very hard for me to sort of imagine the impact that it'll have on so many of our patients, who disproportionately rely on, this sort of door was opened for them. And I just, I have real concerns about, the proposed rule. I absolutely think it's wonderful that, the mental health services that'll continue through telephone is incredibly important and necessary. But for, chronic disease management and, low complexity care, of course, it's not a one size fits all for all type of care. But gosh, telephone, just speaking from personal experience as a primary care doc, the last 18 months doing many telephone visits, it's been a lifeline, for so many of our patients.
Yeah, absolutely. And we don't disagree with that. And I encourage people that have insight and good ideas to please reach out to us to share them and share your observations so we can make the best decisions that we can make. The other side of it, of course, is a lot of unknowns. So for all of these telephone visits that are very focused and very simple, again, as a doctor, a primary care doctor, you're not able to see the skin lesion on their shoulder that avoids the melanoma that, 10 years from now, what I mean? There's a lot that goes on, and it's just more complicated than it seems. And what we don't know yet is what's going to happen 10 years from now. We do know that people are accessing care more easily, and we celebrate that. And we obviously made the flexibilities and made more flexibility. So we're not against the idea. We're just trying to do it correctly so that we enable people to have the best health care that they can get, and that we pay for it correctly, and not just because we're paying all, the money that we pay out, that $100 billion that we spend is all of our money that goes in. So we want to be sure it's done correctly. And unfortunately, not all providers, practitioners are as careful with taxpayer money as those on the panel here today. So, we have a whole center that I worked for a great deal, the Center for Program Integrity, and do a lot of work outside of CMS and with respect to fraud and things like that. And we are always busy, I'm sorry to say, for people who are willing to try and cheat the system. So catching that Goldilocks level of giving the flexibilities to allow the good doctors to do the good work, and not make it so easy that people can just have a call center somewhere and pretend to be giving services and there's no way of catching, is something else that we're trying to be careful of too. And weighing out even though someone's going to game any system, to making it really easy to game the system, is part of the trick to it. So, but please, call, set up meetings, send us letters, show us your data. That's how we learn, and we do our own internal evaluation of data and findings, and we have our own teams of creative minds working on things. Like I know Timothy was talking about before, some of the alternate payment models and different models that the Innovation Center does. We did a bunch of other models for other things. I was involved in a number of models for review processes that really saved a lot of people and saved a lot of money. So there's lots going on, and we can always do more, and we want to do more. So please, reach out and give us your ideas, share your findings, and and we can learn from that and try and make better policy and you know, do the best we can by the patients and the doctors.
Scott, that's a thank you for the invitation. This is a largely research audience, so I think that's a great opportunity if we can take some of our research findings and reach back out to you about the state of current policy. I actually wanted to bring up a question. One of the clear differences between video and telephone is basically there's just there's less data that you can gather from a patient without a video image or the image of the home. But video also lacks many of the biometrics that we rely on when we see people in person, the physical, the old-fashioned physical exam, the blood pressure measurement, the physical assessment, which raises the question about the role of this remote monitoring. And Megan, I wonder if you want to talk about kind of the state of remote monitoring and where is there a sort of a future where if we had more remote monitoring, we would be able to do more even telephone visits with data?
Sure, I can take a stab, and I'm sure Sachin has some feelings on that as well. Most of the work that I do in remote patient monitoring is using devices that don't yet have a charge associated with them. They're kind of innovative mobility monitoring and using accelerometers, for example, and how that information might augment or even replace what we can do in the clinical setting. And I do think that we now have quite a few large epidemiologic research studies that have at least documented the feasibility of using large-scale remote monitors to assess patients in their home doing what they would do normally, just walking around their house. So I am excited about the possibility that that kind of information can be very valuable. As a researcher, as a clinician, I'm scared about the overwhelming amount of data that could flood me, and I don't know how to interpret it. So I do, I think that the University of Chicago, and Sachin, you probably know more about this, but the University of Chicago is piloting vital sign monitoring in certain patient populations, high risk for readmission, and they have sort of direct translatability into our current healthcare system. It's blood pressure, things that we know how to monitor, glucose monitoring, heart rates, things like that. But some of these novel metrics like mobility measures, we just don't know yet how to interpret or use. So I think, there's a couple issues that are still very unclear in my mind. One is just, what's the best place for this data? Is it in a population health level where we're kind of risk stratifying people and identifying the highest risk segments that maybe need more high level, high touch care? Is it so that would be more of like a screening kind of level, or is it to give us supplemental clinic visit on a one-to-one patient level where we're actually monitoring them over time and looking for early declines and catching their cognitive impairment early or their physical function decline early, so we can intervene and it's used sort of as a trigger to interventions. I don't know the answer to that yet, and I feel like we still have a lot of work to go to translate some of that information into something that has clinical value or clinical meaning. I think another major issue that I actually wanted to bring up to the panel is just, a lot of these platforms are industry sponsored, and they're not nonprofit institutions. They have a lot of commercial interest. And so, I personally have had to partner with industry just to get things moving, just to test these innovative tech models, because we don't have the resources internally to do this kind of work. Yet it's really challenging to say, well, how do I integrate this clearly conflicted relationship or potentially conflicted relationship with moving, clinical care forward, improving, access to care, and not sort of being biased in any way. So I guess, that how we best leverage these industry research and clinical relationships is not yet clear to me. And I think industry has to be part of the conversations about privacy and data security and equitable access if we're going to go down the route of these remote biometrics and other telehealth things. We have to have some standards for their care delivery. So those are just a couple of quick thoughts. Lots of potential value, but some things we need to address as we explore them.
Can I weigh in on what Megan just said? Because just a real quick, I think this is a really important point that she made about industry. A couple other things I'd add about that is the difficulty of getting data out of the for-profit sector. The private sector is a troubling thing as a researcher, probably troubling to CMS as well. But it also, having worked with some of the private industry, when in some of these meetings, they'll say, oh, we're trying this really cool thing. I'll say, well, have you evaluated this? And we say, well, we looked at the ROI. And I go, thanks for laughing, Albert. That's great. Because that's what I usually do too, is laugh. Because that's not what you and I think of as an evaluation. And I go, really? Okay. So, and they go, well, yeah, it really works. So, and I think, there's some pretty cool ideas out there, but, you really need to, we need some really good evaluations, and what we think of as really solid peer-reviewed evaluations of some of these things to know that they're really improving outcomes, so CMS can know whether they should spend money on them or not. I'll just stop there.
Great. Rachel, did you want to bring up some questions that are in the chat?
Sure. So we'll switch gears a bit. I'm going to go back up to the top here. This first question was actually from Megan Heising-Sheets. And you had asked if the University of Chicago is working on any interventions for our local patient populations to help overcome the barriers with internet access, tech literacy, and so forth. I'm not sure if maybe Sachin, if that would be appropriate for you to answer.
Yeah, so I think Megan, maybe the question came in before I got to that part of my talk, but I did try to highlight some of the stuff, around, the patient-facing resources, the neighborhood-specific, guides to places, like, community libraries, the digital literacy efforts we're making, the kind of portal or EHR agnostic kind of channels of communication with our patients to share those resources. And then the embedded digital navigation, basic digital navigation, but digital navigation nonetheless, that our care teams are providing. And, like with all kind of limited resources, risk stratifying some of the allocation of that resources with some of the predictive analytics tools that we're developing. So it's a step in the right direction. Of course, this digital divide, that we all talk about, and it's well described and it's easy to describe. It's easy to sort of show it, but to lay to lay the groundwork to bridge that divide is much harder. Megan, you're doing a lot of that work. There's a lot of people that are doing, that are taking concrete steps, but of course it takes time. And it's a hard population, right? It's a hard population to bridge that divide with, especially if we don't intentionally focus on them, right? If we don't say that, this innovation that I'm working on, and this goes back, to Megan's comments earlier too, with this academic sort of industry partnership, is focused specifically on Medicare and Medicaid beneficiaries, because these are the ones that are disproportionately shouldering the burdens of chronic disease, and these are the ones that have the greatest levels of morbidity and mortality from COVID. But even well before that, the chronic diseases. It's easy, it's easy to innovate for those who are already digitally literate and well off. It's much harder to do it for the ones that we've already left behind. And that's what we have to do. That's what we have to insist on. And if we are going to, if we are going to pay for some of this stuff, then yes, we need standards. And those standards, must include, an assessment of the equity, of the intervention that you're proposing. It can't just benefit a subset of the population. It has to be an equitable intervention that benefits, the entire spectrum of our population, of the patient population that you're serving. So again, those are broad strokes, and but I think that those are the standards that we have to hold and insist upon. And just Megan, to your earlier point too about like this avalanche of data that we are inviting. So the remote patient monitoring sort of pilot that we're doing here, and yes, we partnered with a third-party vendor. We evaluated a bunch of them. We settled on one, and I know we did a demo together. And so one mechanism, there's a couple, but one mechanism is that that third party ends up looking at the raw data, right, and distilling out, okay, here's what's clinically meaningful, and that should be going to the care team. So again, it's an element of risk stratification, is so the background sort of the background stuff that I'm not worried about, that's normal physiologic data, or it's within the acceptable sort of limits of I don't need to know about it, that group handles. Down the road, as we get more and more sophisticated, this should be managed by disseminated AI technology and machine learning. We have these algorithms can manage the complex sort of data sets, and then again surface the stuff that is clinically meaningful, clinically important, and send that on to the care team. So it's not everything. It's just, again, it's the signal and not the noise. I think that's how we have to do it. And I think at some point we'll get to maybe like the screening level stuff that you're talking about. But I think we start with chronic disease management. Like I think we start with sort of higher risk groups, specific interventions, like, hey, this woman was had hypertension throughout her pregnancy. She continues to have it postpartum before discharge. I need to monitor this over the next month to make sure that it's going down with the treatment that I'm providing. This patient has congestive heart failure, and I need to know what their daily weights are, or twice daily weights are, so that I can pick up on a 1 pound change before it's a 10 pound change with respiratory distress and hypoxia. I think those are the directions that we're starting, and then eventually we can sort of, as we get more sophisticated with the ability to manage this data, and the cloud-based infrastructure and this dissemination of AI and machine learning will help us tremendously in I think evaluating that and making it clinically useful and actionable.
So let me just ask each of you kind of a last question before we end our Q&A. This has been really an amazing conversation. Tim actually described the entire COVID-19 era and virtual health as a kind of a grand experiment. And that's where I want to kind of ask all of you. Some of the people on this audience are really smart graduate students, medical students, young doctors. So I want to ask each of you the same question. What do you wish a smart young investigator could answer about the COVID-19 pandemic and virtual healthcare? What sort of question do you think that they should pull out? We actually have national Medicare and Medicaid claims data, as has been mentioned earlier. We have other data sources locally. What's a question that you would want a young person to answer?
Who do you want to start, Deb?
Let's start with you, Tim.
Okay, well, thanks for giving me the credit for saying that about the pandemic. I think it is like, we see a few of these every once in a while. a great exogenous change that we didn't want to have happen. But, you know, we could look at this. I think we, you know, through the data that CMS has and others can look at, we can, we know the broad scope of what's happened, but I don't think we really know some key questions like causes and outcomes. So, you know, some of the things I'm wondering about that get to your question is like, I wonder a lot about quality of care. And that would be my first place to go in the disparities questions. You know, we know there's some disparities that have popped up in the data. So I want to know about that. Not only just across race and ethnicity, but across space and geography, and payment and all that. And I want to know also finally, as we get out of the pandemic, praise God, that we do, you know, I don't think we're going to put the genie back in the bottle. I think Scott would agree with that. I think we'd all agree with that. But if we don't, we're going to partially put it back in the bottle. I think we're going to change reimbursement. And as an economist, I think that's going to lead to pretty profound changes backwards on this. So what's going to happen if we do that? I'll just stop there.
Great, thank you. Megan, you're next on my screen, so I'll just ask you the same question.
Sure, I'm gonna actually ask for two things, so hopefully that's okay. But I would say, I don't know if this is an answer, a question I want answered, or just an issue we need to address, is we have to fix the internet access inequitable. Everybody has to have internet, period. It has to be high quality and it needs to be everywhere. And I would just, not only just coming from a rural area myself, but also seeing the difficulties in the Chicagoland area and the heterogeneity of internet quality access among our patients, that has to be addressed. The other thing I do want to ask, and this is something Sachin brought up, that it also came up during the rural health talk, is, and is very relevant to me as a geriatrician. The care that I provide in my clinic visit is just like a fraction of someone's overall health. And the actual meat of what happens to them is their day-to-day life. And when I, spent already 2 hours over the last day performing unbillable video, phone calls to patients, or I want to give them some support programming that actually supports their care in between those visits using technology, whether it be telephone or otherwise, that's where I think we need to support our patients using these technologies. So what I want to answer, or what I would like an answer for, is how we can measure the impact of the care provided in between visits, because I really think that that's where most of this care is happening, not in the 15 minutes that I see a patient.
Thank you. Great question. Scott?
Thank you very much. I'd like to thank you for including me on a panel with Dr. Shah, Hussein-Sheets, and McBride. This has been a very fascinating melding of minds and ideas. My question that I have for the young minds and bright thinkers in the audience and on the panel is, how do we design a system that catches the people that aren't able to access healthcare in a way that doesn't allow a floodgate of other people to get healthcare or get poor healthcare? So to get quality care to those people that aren't getting it, like the people that aren't able to access. Forget about broadband in general. There's some people that just aren't able to use a computer, period, because of some physical disability or something like that. So there's a whole equity piece that we're trying to aim at, and I'm looking to see if people have creative ideas how to capture those people in a meaningful way that can happen on a national scale. And I'll stop there. Thank you very much for everyone's time and attention. And I hope some people got a good nap during my presentation on the physician fee schedule.
No, I don't think so. And Sachin, we'll end with you.
Thanks, guys. Yeah, I mean, I think my big question is around how do we effectively risk stratify our population? I think there's a big difference in terms of, there's a wide spectrum in terms of what my patients can do, can access, can self-manage. So, I want to give, I think that one of the real keys to unlocking this new model of care delivery is making sure we understand what our different patients, what their needs are. So if I can give, transparency to their information and agency to a significant subset of my patients, and they become more engaged, more activated, and they can self-manage and improve their outcomes, that's great in so many ways. And not the least of which is that it frees up some of the resources that I have to really focus on my higher complexity patients who don't have that same sort of wherewithal to self-manage. And if we can effectively risk stratify our population, we can more effectively allocate the limited resources that we have currently and will always have. And finding ways to design pilots. And I think this is, this is dependent on, a value-based payment model that we've talked about too, but designing pilots, testing them, showing that they work or don't work, scaling them accordingly. I think these are some of the really big questions that we have to answer and prove.
Great, thank you very much. And I guess a round of applause from everybody for our four speakers. Thank you to each of you for amazing talks. And we'll be back at 1 o'clock for our poster award winners. So thank you. We'll see you at 1 o'clock.